Now, the next speaker is Stuart McIntosh, and I seem to be following Stuart wherever he goes. So I went to Leeds to do my MD, and he was the oncoplastic fellow. Then I came to Aberdeen to do my job here, and he was in Aberdeen before me. And now he's in Belfast, so I don't know where I'm heading next. So Stuart is one of the consultants in Belfast, and he was one of the lecturers there. And he leads on many of the national trials, as we heard also from Ian. And it's great to have him on board today. Stuart, the next 15-20 minutes are all yours.
Thank you very much, Yuzan, and thank you for the kind invitation to speak. I'll be looking forward to seeing you joining us in the team in Belfast before too much longer. Right. So thank you. And I have to say that, Ian, thank you. That was a great talk. It's a hard act to follow, but I'll do my best. I hope you can see my screen all right there. And I am going to talk about the use of neoadjuvant chemotherapy as a surgical tool from a surgical perspective. And really what I'm proposing to do is have a look through the evidence supporting that. I think the management of the axilla was pretty comprehensively covered in last week's webinar. So I would start with a disclaimer and say that I'm going to focus very much on the treatment of the primary tumor in the breast in this talk. And that's really what we'll be focused on. So I think it's fair to say that over the last few decades, we've seen the role of breast surgery evolve substantially. And we've moved on really from the days where more is better, a bigger, more radical operation is the only option. And we approach all our patients in the same way with a one-size-fits-all approach. I think with improvements in treatment and improvements in approaches to patient selection, we've seen surgery moving to a much more individualized approach where we can carry out the minimum necessary surgery for effective disease control to achieve really good oncological outcomes. And that is where surgery sits within a combination of multimodality therapies. And I think that's really important, and I think it's important to stress, as Ian did at the end of his talk, that this is very much a multidisciplinary team game, and I think that'll come across from both my talk and also from Fiona's talk as well. So from a surgical perspective, why do we want to use neoadjuvant chemotherapy? What are the benefits for us and for our patients? Well, this is a slightly more graphic version of Ian's elegant slide taken from the overview data. We use it to reduce tumor burden. Historically, it was used for the treatment of locally advanced and inoperable breast cancer, and more recently, it's been utilized to allow us to downstage tumors, to convert from mastectomy to breast conservation, and to reduce excisional volumes to achieve better aesthetic outcomes and oncoplastic approaches. It also gives us time in some cases to consider complex surgical options, and we can use that time for young women with triple negative breast cancer, for example, to carry out BRCA mutation testing or make decisions about reconstructive surgery where we know a patient is likely to require a mastectomy after treatment. Ian has covered this slide, and inevitably there's a little bit of repetition. I think that the other and arguably more important use of neoadjuvant chemotherapy is to obtain the sort of information that Ian's been talking about, to achieve a pathological complete response, to assess the sensitivity of a tumor to chemotherapy. As Ian said, this is highly prognostic, and I'll come back to that in a moment or two. It also allows us, as you've heard, to tailor further systemic therapy. And once again, we've got Catherine on the left in HER2 positive disease and CreateX on the right in triple negative disease, showing the potential benefits of tailoring adjuvant systemic therapies in the event of pathological non-complete response. So I move on. I'm going to park that because you've heard quite a lot about it already. I think there are a few definitions that it's quite useful to get under our belt before we go any further, because I've just said that the aim is to achieve a pathological complete response. And what is that? That's a good question, because there are a variety of definitions of PCR floating around. But I think we would probably all agree now that the key definition for us to use is no residual invasive disease remaining in the breast or the lymph nodes. And that's what I'm going to mean when I talk about PCR for the rest of this talk. Why PT not? PTIS, residual in situ disease in the breast, is permitted in this classification, but no residual nodal disease. And as Ian has mentioned, there are a number of different systems to quantify residual disease, but probably the best one, certainly the most validated one, is the residual cancer burden system, which developed at MD Anderson, takes into account the diameter of the tumor bed, the amount of viable tumor cells that are left, and any residual nodal disease, including the size of that nodal disease. And that information can then be entered into an online calculator, which gives both a residual cancer burden score, but also a class from 0 to 3. And who gets a pathological complete response? Well, I think this is data from a meta-analysis. It's slightly older than the one that Ian showed you, but I think the data here is still highly relevant. It shows essentially, if you look at tumor grade here, we see very low pathological complete response rates of around 7 to 12% in low grade, grade 1 and 2 tumors, much higher PCR rates in grade 3 tumors. And again, if we look at tumor subtype, there is a huge variation according to subtype, with ER positive low-grade tumors again having very low response rates, much higher response rates seen in triple negative and HER2 positive disease. And I think this is really important information to bear in mind when we're thinking about selecting patients to use neoadjuvant chemotherapy as a surgical tool. I think you would have to look very hard to have a justification for treating ER positive disease, particularly node negative ER positive disease, with chemotherapy in the neoadjuvant setting. And again, you've seen this already a little bit. This is basically looking at long-term outcomes in patients with pathological complete response versus no complete response. And again, if we drill down looking using the residual cancer burden data, looking at both triple negative and HER2 positive disease, again, you can see that the residual cancer burden is a good predictor of longer term outcomes in terms of relapse-free survival. So PCR clearly is a good thing for patients in terms of long-term outcomes. But the question for us as surgeons, I suppose, is how do we maximize PCR rates for our patients? You've heard a little bit about that from Ian. And what are the benefits? And I think there's no doubt, given the information that I've shown you, given our knowledge about tumor biology, that we can better select patients who are going to benefit, the triple negatives, the HER2 positives, and we have better targeted therapies available, as Ian has shown you. And that really facilitates, these are a couple of big neoadjuvant studies, NSABP-B27 and NeoAlto, both looked at neoadjuvant therapies, and you can see in the experimental arms, the neoadjuvant therapeutic arms, you can see that we were able to really pretty much double pathological complete response rates in these studies. But interestingly, this didn't really have any impact on the rate of breast conserving surgery, which does really raise the question, are we as surgeons really leveraging the benefits of neoadjuvant chemotherapy for our patients in terms of surgical downstaging and increasing our ability to conserve the breast? So what about some perhaps slightly more modern, some more recent data? This is a single center series from MSK in the US, 600 patients with stage 1 to 3 disease, all of whom had what we would probably consider pretty much optimal dual anthracycline taxane chemotherapy, with almost all the HER2 positive patients having dual antibody therapy. And they looked at outset, they had just over 400 patients who were not eligible for breast conserving surgery. And of those, after neoadjuvant chemotherapy, 2/3 of them actually converted to being eligible for breast conservation. Of those 286, only 2/3 actually had breast conserving surgery, 1/3 had a mastectomy, and you can see here the differences in pathological complete response rates between those two arms. So interestingly, the vast majority of the patients who were eligible for breast conserving surgery who chose to have mastectomy had this for reasons of patient preference. And in this series, the major predictors of successful downstaging were receptor status, so as I've shown you, triple negative and HER2 positive disease, and also the achievement of a pathological complete response. Some more modern data this is a multi-center series. This is looking in a highly selected triple-negative breast cancer triple-negative breast cancer population in a clinical trial of brightness, which Ian has already mentioned. And this really looked at 600 women with stage 2 to 3 triple-negative breast cancers. And what we saw here, again, about a 50% conversion of patients from the mastectomy group to the breast conserving surgery group after neoadjuvant chemotherapy, with a pathological complete response rate of 49% in those patients. Overall, however, the mastectomy rate in this study remained at 43%, and there was an interesting geographical distribution of the mastectomies, particularly patients having bilateral mastectomies in the absence of a germline BRCA mutation. So I've shown you some US data, I've shown you some global data. What about the UK? What happens in the UK? Well, we have recently carried out the NEST study, the neoadjuvant systemic therapy study, supported by the Association of Breast Surgery, and 39 UK centres took part in this series. And when we asked at the outset of the study what centres did, 3/4 of the centres said they carried out response adapted surgery after neoadjuvant chemotherapy, only removing what remained, whereas 1/4 would reset the original disease footprint and that had been present at the time of diagnosis. And we then carried out a prospective audit. We collected data on just over 900 breast cancers, and at diagnosis you can see that 53% of those, just over half, were not eligible for breast conserving surgery. And after neoadjuvant chemotherapy, 45% of those did actually have a mastectomy, and there was an increase in the number of patients clearly who were able to have breast conserving surgery. So fewer patients requiring mastectomy and increased breast conserving rates consistent across the 3 series that I've just shown you. But again, in NEST, we saw that there was still a significant proportion of patients undergoing a mastectomy who had a pathological complete response. So I think there's still some work to be done in terms of maximizing the benefit for our patients of neoadjuvant chemotherapy. And I think there are a few questions we probably need to ask around the question of whether breast conserving surgery after neoadjuvant chemotherapy is not being carried out more. Is it because there are concerns about the oncological safety of response adapted surgery? Is it because it's difficult to predict how much tissue requires excision after chemotherapy? And how do we define the actual disease response preoperatively? Because there's no doubt that there are challenges associated with radiological response assessment, how we assess PCR in this setting pre-surgery, and also what we do about microcalcifications, which I'll come back to. But I'm going to try and answer each of these questions in turn using the evidence base that's out there. And the first question clearly is whether or not breast conserving surgery after neoadjuvant chemotherapy is in fact oncologically safe. There is a lot of data. It's not all randomized data. There's not a direct randomized comparison, but there are over 5,000 patients out there with more than 15 years follow-up. We can see that the large NSABP studies from the US showed equivalent local regional recurrence rates. The Marsden series from 2005 showing that although there was increased local regional recurrence if no surgery was carried out at all, and I'll come back to that at the end, there was no survival difference at 15 years. And similarly, the Cochrane review carried out in 2008 showed no increase in local regional recurrence unless surgery or radiotherapy were omitted after neoadjuvant chemotherapy. But probably the best evidence comes from the large EBCTCG overview, which again Ian alluded to earlier, published in 2018. And this looked at, this was a patient level meta-analysis, and this looked at patients having neoadjuvant and adjuvant chemotherapy in the trials, showing clearly more patients undergoing neoadjuvant chemotherapy and an absolute local recurrence difference of 5%, 21 versus 16% at 15 years. And if you excluded trials where patients had no surgery, this absolute local recurrence difference remained significant at 3%. However, when we look at the longer, the distant recurrence and breast cancer mortality and death from any cause outcomes at 15 years, we can see there is no difference in these key oncological outcomes at the 15-year mark. So to answer that question of is breast conserving surgery after neoadjuvant chemotherapy oncologically safe, I think you have to remember that that meta-analysis is looking at historical data. We've got a very wide range of patients with unselected tumor biologies. We didn't always know their tumor biology. Some of this may have predated our knowledge about HER2, no anti-HER2 targeted therapies. But despite these limitations, we can see from the meta-analysis that we achieved good disease control with local recurrence rates only 5% higher and no survival detriment. And we have to consider now that we have significantly improved PCR rates. As I've talked to you about, we have improved patient selection, improved therapeutic regimes, and we have much better methods of assessment and monitoring of disease. So how can we maximize the surgical benefits for our patients? Well, as I've said, as Ian has said, this is multidisciplinary. There's a question around whether radiological monitoring and response assessment, which is key, can predict complete response to neoadjuvant chemotherapy. And to hear about the practical aspects of that, you're going to have to wait for the next talk, which I'm looking forward to hearing Fiona talk about. So, but just coming back to think about the imaging, because the problem with imaging is that we know if we look at this series, this paper looking at the ability of imaging to predict PCR after neoadjuvant chemotherapy, what you'll see is that both mammography, ultrasound, and MRI are not great predictors of pathological complete response. The false negative rates seen in these columns, 9 to 70% for mammography, 9 to 70% for ultrasound, 4 to 50% for MRI. These are the percentage of patients who had residual tumor at pathology that was not seen on imaging. And the negative predictive value represents the percent of complete responders that were accurately identified by imaging. So you can see that imaging alone is not a reliable predictor of PCR. And there is the issue of microcalcifications, which are difficult because microcalcifications may change throughout neoadjuvant chemotherapy. And there's quite a lot of data out there showing that changes that neoadjuvant chemotherapy may increase. Perhaps new calcification can appear due to the death of tumor cells. Existing calcification can change, and it's been shown that changes do not correlate well with MRI or with pathological response to treatment, and that not all calcification represents viable tumor. Indeed, mammographic calcification has been shown in that MSK series that I presented to you earlier of surgical outcomes. It's been shown to correlate very poorly with post-treatment tumor size, and that reductions in microcalcification don't predict PCR. And you can see here that down on the left, you can see in this series, again, the same MSK series, changes in microcalcification, resolving, reducing, no change, increasing, or new calcification appearing, and really PCR rates hugely variable. So change in microcalcification not predictive of PCR. And in this series, the investigators were unable to identify a subset of patients where we could safely leave calcifications in place after surgery. So microcalcification may or may not be associated with tumor, can't predict response from these changes, and you really need to be very aware of this when selecting patients for neoadjuvant chemotherapy. I'm straying into the practical aspects here, but although extensive calcification I wouldn't consider to be a contraindication to neoadjuvant chemotherapy in the context of triple negative or HER2 positive disease, you have to think very carefully about what the aim of treatment is and whether actually you will be able to carry out surgical downstaging in that setting. So I want to take the last minute or so to talk about the possibility in the future of omitting surgery after neoadjuvant chemotherapy. Is this a possibility? Because there is some data to suggest that it might be. It's a series from Alistair Ring and colleagues at the Marsden, published in the early 2000s. It's a retrospective series looking at about 130 patients who had a apparently complete response to chemotherapy. About half of them had surgery, about half of them did not have surgery, had radiotherapy alone. And we can see here that there is no difference at the 15-year mark in terms of disease-free survival between surgery versus no surgery. Similarly, the Bordeaux trial, which is over 20 years old now, looked at group A, where patients who all had mastectomy after neoadjuvant chemotherapy. Group B were a mixture of mastectomy, breast conserving surgery, and radiotherapy alone with no surgery. Again, we see that there's no difference in overall survival at the 15-year mark. So is it possible there's a group of patients who have a pathological complete response to neoadjuvant systemic therapy who don't need surgery? Possibly. Would it be good if we could identify those patients at the end of their chemotherapy? Yes, clearly it would. And the question really here is, can we predict PCI using a combination of imaging and biopsy? And this has been looked at in several series now. Probably the best data is from this pooled multi-center analysis from the Marsden, from MD Anderson, from South Korea, which looked at 166 patients of varying tumor phenotypes who all had imaging and image-guided biopsy, mostly vacuum-assisted, some core needle biopsy at the end of their chemotherapy. And this showed an overall false negative rate for this approach of 19%, although when certain criteria were applied, a residual radiological lesion of less than 2 centimeters in diameter and over 6 cores taken, that false negative rate dropped. So it is quite possible that in the future there may be patients where we can identify PCI using a combination of imaging and biopsy. There are further trials ongoing looking at this, and I think we await the results of those with interest. So in conclusion, if we look at the evidence, I think we can say that neoadjuvant therapy is indeed a valuable surgical tool for us, and it can reduce the extent of surgery while being oncologically safe. Omission of surgery could in future be a possibility in patients with exceptionally responsive disease, and successful neoadjuvant treatment is a multidisciplinary approach. And I'm going to hand over to Ms. McNeil to tell you about that. Thank you very much.
Many thanks, Stuart, for the lovely talk. Great to see now more than 500 people online.